Well, hello everybody. We want to welcome you back to another episode of Surviving and Thriving in a Pandemic. Today we have a special topic, and guess what? We are on location today at Emory Decatur. Here in Emory Decatur, right now we're in the colorectal department, and I'm going to introduce you to our guest. But did you know, I think all of us were kind of shocked when we heard about the passing of Chadwick Boseman. His passing from colorectal cancer at the young age of 43 years old. It is serious, it's common, but we don't talk about it. So today we have a doctor with us today who's going to talk to us about colorectal health, all things colorectal health. Dr. Raul Meyer specializes in medical and surgical treatments of conditions that affect the lower digestive tract. So today I want to welcome you, Dr. Myers, for being on our show today, Surviving and Thriving. Thank you for welcoming us to your practice today.
Thank you very much for having me over. I really appreciate it. Thank you.
Thank you. So as I was introducing and saying, Chadwick Boseman, when we heard of that, we were just so shocked. It's shocking to hear somebody so young passing of colorectal cancer.
That was a real blow to a lot of people's kind of outlook on life in general, because he was so vibrant and quite good at what he did, and he was a spectacular movie personality. I think a lot of the young people kind of identified themselves as being that generation, including my own son, who brought it up to my attention. Mm-hmm. So I think it's a good example where we can try to make a difference, and the way to accomplish that is colonoscopy screening for colorectal cancer.
Okay.
And that's my message, basically.
Mm. And so I'm happy that you mentioned the screenings, because I think we thought this is for older people, not for younger people. And even as I've been reading now, in 2022, about 12% of colorectal cancers, about 18,000 cases, will be diagnosed in people under the age of 50 years old here in the U.S. And so that's surprising even to me that the rate of colorectal cancer is more common now in people under 50.
We have seen a constant move towards a younger age of diagnosis, and I think we're heading in the right direction. We have screening colonoscopy that's been instituted initially age 50, and now the new indication is age 45. My prediction is that we will be looking into moving that age group even to a younger age, especially if their coexistent risk factor is in play. And I think in my practice I have seen a good number of people who are in their 30s and are diagnosed with colon cancer. Wow. So it's not that uncommon.
Mm. And so I love that you said even his former cancer, you said that it's, well, in our earlier discussion, you mentioned that he had a type of cancer that was not curable, but that it doesn't have to be our prognosis if we do.
Well, that's timing is everything. So in other words, if the tumor is diagnosed at a very early stage, or even better, the precursor to the tumor, which are the colon polyps, that's what we're after, are diagnosed early, then we prevent colon cancer from developing. I think in his case, he probably had a very aggressive tumor from the get-go. He had what's called stage 4 colon cancer, which means the tumors metastasized to other organs in the body, and there's usually no cure for that.
Okay. And so you mentioned the polyps, and I know that you mentioned colonoscopies. Can you talk to us about what a colonoscopy is?
Colonoscopy is the examination using a flexible endoscope of the large intestine of the colon. The terms are interchangeable. Colon and large intestine is really the same thing. And the way colon cancer starts is a little abnormal growth, what we call the polyp, which is not cancer, but it's a precursor to the cancer. If we do the colonoscopy early enough, we can remove the polyps and then prevent colon cancer from ever developing. So that's the strategy.
Okay. And you were saying earlier that we should get them if our family member has had
Sure.
previous history.
That's a risk factor. The colonoscopy should be started earlier. And any symptom, I mean, you cannot just assume, for instance, bleeding is coming from an outlet source like hemorrhoids or fissures. If you have bleeding, you need to have your colon looked at.
Okay. And so what are some other signs that we should be looking for when it comes to this colorectal cancer?
Well, let me just break this into two categories. I think what we're striving for is having a screening colonoscopy. In other words, colonoscopy without symptoms. And then the way you can, help to diminish the rate of colon cancer is to start it earlier, especially if you have a risk factor.
Okay.
So sometimes earlier than 45, if you have a family history of colon cancer or other members of the family have inflammatory bowel disease or any of those other conditions. So screening colonoscopy, I think, is where you can make the most difference. Now, colonoscopy for symptoms, it should be done promptly if there's any bleeding, change in bowel movements, not specific of bowel pain, any one of those things. We all know our bodies. If we notice something is different, then don't just ignore it. See a physician for that.
I love it. So we should all have a baseline colonoscopy is what I'm hearing.
Correct.
We all
Correct.
should have one. Doesn't matter.
Yeah, absolutely. It's easy enough to do. Yes.
Just like even if women have breast exams, that's the baseline. We need to do the same thing I'm hearing. With
It's
our
absolutely the same. Yes.
Absolutely. Okay. So that makes sense. So let me ask you. You also talk about you have a list of items or conditions that you treat. So hemorrhoids, you mentioned that earlier. Let's talk about them. We have them, folks. We know people who've had them. I want to talk about those. How do we get hemorrhoids? How do we get rid of them?
I think the most important change that we can have is dietary changes with increasing the fiber intake and increasing the fluid intake. And if you have hemorrhoids, it doesn't automatically need a surgical procedure. Medical interventions can really take care of most patient symptoms and less invasive procedures as well. But I think we need to concentrate on our dietary habits. And that's probably very important.
And so even with our dietary habits, sometimes we can use enemas, we can use laxatives. When is too much?
I would just stay away from enemas and laxatives. I think if you have a combination of increasing the fiber intake, using fiber supplements, and or increasing the fiber in our diets, in conjunction with having adequate fluid intake, then I think that will reach the goal of having regular bowel movements. That's what we're aiming for, regular bowel movements.
Okay, all right. And then even as women, I know that sometimes after childbirth, the pushing and
yes. I think that comes with the territory. My own wife is this person who had trouble with hemorrhoids that subsequently improved, but I think it's difficult because pregnancy changes a lot of things. There's no doubt about it.
Absolutely. And so I'm even thinking about, when we talk about hemorrhoids, we always link it into constipation.
I think that there's a relationship there. So I think having normal bowel movements is probably what prevents most people from developing symptomatic hemorrhoids.
Okay. And so if we do, when do we need to come see a doctor when it comes to constipation? When do I need to come and see the doctor?
I think it's a question of basically, is it really just a benign situation, or is it more than that? If someone has a change in bowel movements, it could be related on some occasions to malignancy.
So it could be, and we would need to come and see you.
Right. If your body's telling you something, have the symptoms checked. Absolutely.
Okay. And so, two conditions that I always hear about, especially in our African American community, is Crohn's disease and diverticulitis. Could you speak to those a little bit?
Absolutely. Let's start with diverticulitis, which is probably a little simpler. I think that's also due to inadequate fiber intake. So that's what leads to diverticular disease. And in this pandemic age, we've seen a lot of patients that had symptoms of diverticulitis, which were initially minor and became more serious with time. But because of the COVID pandemic, a lot of patients were afraid to come to the hospital, be evaluated. And what we have now is a lot of very complicated cases of diverticulitis, and I think that's been a big change. As well as in the same category, patients with advanced malignancies, because patients did not seek medical attention. So we're starting to see an increase in the detection rate. Crohn's disease is something that's it's a chronic condition, and it's a multidisciplinary type approach to treating Crohn's. We need to have gastroenterologists and surgeons involved in the treatment, and unfortunately it's a lifelong problem, and I think it's important to start the treatment early and try to, because it affects a lot of young people. And I think nutrition or inadequate nutrition is not uncommon, especially in patients with small bowel Crohn's disease, and seeking proper medical attention is very, very important.
So I hear you guys, you're hearing it right now. I know that some of us have been afraid to go to the doctor, but please go and get your checkups. And if you feel something, please go see your physician, because we don't want it to get advanced. We have great doctors here who can help prevent and possibly even restore your health. So we're thankful for that. So we've talked about some of these areas that are really conditions that are there now, but what can we do to prevent some of these? So let's talk about colorectal health. Let's end on a positive note about the colorectal health.
Okay. So I think it's a multiple prong approach. Number one is, again, trying to have a diet that's appropriate with high fiber, less carbohydrate, less animal fat. So that's, unfortunately, it's an education thing starting from the family.
Yes.
And fast food is out there, and it's very tempting and very, very much available.
The American diet, right?
It's not a healthy diet.
Yeah.
And so dietary adjustments are very, very important. And the second thing is, again, I'm repeating myself, any changes in your body and your symptoms, I wouldn't just, put it off. Have someone look at what's causing something to be different. So there's a very sarcastic joke that I'm going to have to say, and the question is, what's the most dangerous sentence in the English language? And that is, it will go away.
My goodness.
So don't just assume it's something passing that's going to be all. Don't ignore the symptoms, basically.
Don't ignore the symptoms, you guys. You heard it today. Don't ignore the symptoms, whatever they are. Go see your doctor. Go see your doctor.
And we're here in Decatur. I've personally been in this area for 25 years, and we love to make a difference in people's lives.
Absolutely. I thank you. This has been so good. We needed to hear this. Anything else you want to share with the audience as it relates to colorectal health, and anything you want to share with us?
I think we have seen an improvement actually in our screening rates as far as screening colonoscopies, and we have been seeing earlier tumors that we detect. So I think the trend is there. It's just my feeling is we can do better.
Okay. Well, you heard it here. Dr. Myers is asking us to come in and get our checkups. If you feel it, guess what? It's not going to probably go away. Don't wait until it gets worse. Come check in with your doctor. We want to make sure that your health is good and that you're doing well in your lower digestive area. We thank you for the time to come out here in your busy schedule to talk to us about just some of our areas.
Thank you very much for having me talk to you today. I appreciate it. Thank you so much.
Dr. Myers. We're here at Emory Decatur, and guess what, you guys? We want you to share this. Make sure you share with everybody, and we will see you again on Surviving and Thriving in a Pandemic. Have a great week.
Our practice is Emory Decatur Colorectal Surgery, so that's how you can find us. Thank you so much.
And we'll get your information on there as well.
Thank you.
So you've heard it here today. We'll see you guys later. Have a great day. Hello, everyone. We also have with us Dr. Luz Angel. She's also a practicing physician here at Emory Decatur. And this, again, is the colon and rectal surgery that provides full service colorectal health for diseases of the intestine, colon, rectum, and anus. You guys, we have already been talking about colorectal health. We talked a little bit about constipation, but I wanted to bring you in and thank you again, Dr. Lukes, for being here today to give us a moment, just to give us some perspective as women when it comes to colorectal health. And so we were just talking a minute ago, but we want to make sure that we talk about this on camera. One thing that I'm thinking about is constipation when it comes to women and even hemorrhoids. I remember being pregnant, and it was a whole introduction to my lower part of my body, my lower intestines. So hemorrhoids and constipation, can you just share a little bit about that and what happens during that process and what do we need to do?
Sure, thank you for having me. It's my pleasure. Constipation, hemorrhoids, a very common issue in everybody, especially women. We don't drink enough water, maybe we don't exercise as much as we could, and maybe we don't eat enough fiber in our diet, enough fruits and vegetables. And during pregnancy, the hormonal changes, the prenatal vitamins predispose to constipation. When I evaluate a patient with constipation, I first go over their diet. What is their water intake? How much fiber do they take? How much exercise do they perform? I go over first optimizing their nutrition. And then sometimes, they have to take laxatives to help them go, and that's okay. Certainly, in an older person, I want to make sure, especially if they're 45 or greater, that they don't have an anatomical obstruction. I ask them if they ever had a screening colonoscopy. With respect to hemorrhoids, the conversation is a little bit similar. First, go over their diet. Do they eat enough fiber? And what are their bathroom habits? A lot of people like to, spend a lot of time in the bathroom, especially now with their electronics. Yes. They read a lot in their bathroom. Going over healthy bowel habits, not spending a long time on the toilet straining. Ideally, you want big, bulky bowel movements, okay, like bananas.
Okay.
So again, optimizing fiber in the diet, drinking a lot of water.
So what I heard, two things: keep the phone out the bathroom.
Definitely. Keep
the phone out the bathroom, you all. And we should have a nice banana-shaped bowel movement, big bulky bowel movements.
Right. Fiber and water, they work together.
And water. And so I talked to Dr. Myers earlier about the American diet. And sadly, we also succumb to that. And so when you say fiber, you said fruits and vegetables. How much approximately should we be looking at? What should we be doing?
Maybe between 35 and 40 grams of fiber a day.
Okay.
And drinking, 8 to 10 glasses of water a day. And exercise.
And exercise to keep moving. Okay. Mm-hmm. And I like that you mentioned over the progression of a woman's life, because of course childbearing age is one thing with our lower digestive tract, and then when we get older it becomes another thing. So I'm even thinking about like when we have those prolapse that you all treat here for conditions. Could you talk about that? Sure.
Usually I see it in older women. Nulliparous women that haven't had many vaginal deliveries. Mm-hmm. It's a very distressing condition, very uncomfortable, and the only way to repair it is surgically. Mm-hmm. There are numerous surgical approaches, abdominal approaches that you could do from the bottom, and the surgical approach is really tailored to the individual patient based on their age and their medical condition. The surgical repairs, I think are pretty successful.
Mm-hmm. Okay. So let me ask you, I asked Dr. Myers earlier, but I know that women tend to sometimes weaken take a lot of teas. So I don't know if you've heard of Smooth Move and all these diet teas that are out right now. Is that something we should be doing? Or should we?
I don't recommend the laxative teas. A lot of them contain Senecot, and that could have side effects on the colon innervation. It makes them dependent upon that tea. So if the patient doesn't respond to the high fiber diet, they've tried the Metamucils, the Benefibers, and they still have difficulty going to the bathroom, then I would recommend an over-the-counter laxative like Miralax, for example. The Senecot teas, laxative teas, the patient becomes dependent upon them, and it does cause nerve damage to the colon.
That's good to know. I don't think we even realize that our body can become dependent upon that. So what are some other areas when it comes to women and colorectal health? I just wanted to get a few pointers from you.
Sure. The other common condition that is prevalent in women is obstructive defecation, difficulty getting the stool out of the rectum. They have dysfunction of the pelvic floor muscles.
Yes.
They don't have enough oomph, okay, to get the stool out. Or they have fecal incontinence. They have weak sphincter muscles from vaginal deliveries. That's probably the number one cause. Or sometimes from overzealous anal surgery, fistulotomies, hemorrhoidectomies.
Okay. And you did mention the pelvic floor. Are there exercises we can do for that?
Sure, there are physical therapists that have expertise in pelvic floor. They perform biofeedback and special exercises to try to strengthen the pelvic floor muscles.
Okay. Well, Dr. Luz, I sure appreciate you taking time out of your busy schedule to talk to us for a moment about colorectal health when it comes to women. So we thank you again here from Emory Decatur. We thank you again for taking the time out to speak with us.
Thank you very much for having me. I appreciate it. Thank you very much.
All right. Thank you.
Thank you.